I presented some exploratory analysis of by-gene subgroups and potential associations with efficacy. So we looked at different markers such as rPFS and OS and overall response rate, as well as PSA response and time to PSA progression. And just for a short memory, the TALAPRO-2 study is a phase 3 study that recruited patients that needed a treatment for first-line mCRPC. We started with recruiting patients that were an all-comer population, and those patients were prospectively tested for HRR alterations as well. But once the cohort 1 was fully recruited, we started to recruit further patients with HRR alterations. So cohort 2, that was the cohort that I presented, consists of patients that have HRR alterations within their tumor. Patients received either Talazoparib plus Enzalutamide or placebo plus Enzalutamide. And the primary endpoint of the study was rPFS and OS, and turned out positive. So that was previously presented at ASCO GU. And we were looking into the sub-analysis or subgroup analysis of the by genes. And basically, HRR was defined as having one of 12 alterations within the tumor tissue or the ctDNA. And we used all data that we had from pre-screening and screening and decided to focus hence on 6 genes, as 92% of the population had one of these, or at least one of these 6 genes altered within their tumor or ctDNA. And we looked at rPFS and saw that for all 6 gene subgroups, which were ATM, CHEK2, BRCA1, BRCA2, PALB2, and CDK12, patients had a benefit from the combination therapy. That was most pronounced for BRCA1, BRCA2 as expected, but also for CDK12 and PALB2, and not so much for CHEK2 and ATM, but still beneficial or more beneficial than the monotherapy. We then looked at overall survival, which again, not surprisingly, was better for patients with BRCA1 and BRCA2 alterations, but also for CDK12. And it was a little bit surprising because for monotherapy, we know that patients did not have so much benefit from the PARP inhibitor therapy. And we assumed that might be possible, or might be potentially because of the dual inhibition of the androgen receptor and PARP. And for the other endpoints, like overall response rate, 5 of 6 subgroups had a benefit from the combination therapy, and also for PSA progression and time to PSA progression and PSA response, all subgroups benefited from the combination. And that was something that probably not everybody had expected. Because a lot of people thought that those effects might be driven by BRCA1, BRCA2 only, but the analysis showed that that was not the case.